This conference will now be recorded.
Today's topic is investigations in ophthalmology. Most important investigation in ophthalmology is visual acuity. Visual acuity is the measure of spatial resolution of the eye, or in other words, an ability to discriminate between the 2 points. The components of visual acuity or vision or visual perception includes it is a complex integration of light, form, color and contrast and sense. All the 5 things together come into visual acuity. It consists of light, form, color, contrast and sense. All these 5 components together come under visual acuity. It is a measure of spatial resolution of the eye, or in other words, ability to discriminate between the 2 points is considered as the visual acuity. Units of visual testing: visual function assessment, refractive status assessment. What are the uses of visual acuity? Testing of the visual acuity includes the uses includes visual function assessment, refractive status assessment, outcome measure for the treatment. If you would have done any surgery in the eye, so what is the improvement in the vision? That improvement vision can be tested with visual acuity. Medical legal purposes: criteria for person's fitness to drive, eligibility for entrance into a profession. Profession is for like pilots, any drivers, auto drivers or car drivers, like that. Particularly for pilots. For doctors also there will be visual acuity testing before you join MBBS. Components of visual acuity includes minimum visible, resolution, recognition, minimum discriminable. These are the components. Minimum visible means the ability to detect whether an object in otherwise ability to detect an object in the empty visual field we call minimum visible. Resolution is clinically a measure of visual acuity. Discrimination of 2 spatially separated targets is called discrimination between the 2 spatially separated targets is called the resolution. Recognition is discrimination of spatial characters and identifies the pattern from memory. Identification of faces is called recognition. Minimum discriminable means spatial distinction of by an observer when threshold lower than ordinary acuity. These are the 4 components of visual acuity: minimum visible, resolution, recognition and minimum discriminable. This is the example for minimum visible: ability to detect an object in an empty visual field is called minimum visible. Resolution is clinical discrimination of 2 spatially separated targets. If we are able to separate, recognize with the 2 spatially separated objects, which is called resolution. You can identify the 2 spatially separated objects, it is called resolution. Discrimination is identification of faces. Spatial characters identify the pattern from memory. This is recognition, identifying the patterns. These are the different patterns. This is one pattern, this is F pattern, this is C pattern, this is E pattern. This is the recognition of patterns. Identification of patterns or faces is called recognition. Minimum discriminable means spatial distinction by an observer when threshold lower than ordinary acuity. Spatial distinction by an observer is called minimum discriminable. Methods for distant visual acuity includes Snellen's visual chart, Landlord's Boken ring, tumbling chart, E chart, Bailey's love chart, or Logmer chart. These are the various methods for testing the visual acuity. Snellen's visual acuity, Landlord's Broken ring, tumbling E chart, Bailey love chart, Logmer chart. These are the various methods for distance visual acuity. These are the Snellen's charts, various patterns. This is alphabets. This is C chart, E chart. These are the Snellen's visual testing. Snellen's charts for testing the visual acuity. These are the various patterns testing the visual acuity. Distant visual acuity. Visual acuity at near vision at a distance of 35 centimeters. For distance is checked at a distance of 6 meters. For near vision, it is checked at a distance of 35 centimeters. There are various tests. Snellen's near vision test type, Roman test type, Jaggers chart. These are the visual acuity for near vision at a distance of 30. This is the Snellen's visual acuity for near vision. Color sense is the ability of the eye to discriminate between the colors excited by the light of different wavelengths. It is a function of cones. Color vision or color sense is the ability of the eye to discriminate between the colors excited by the light of different wavelengths. Color vision is a function of cones. Night vision is a function of rods, whereas color vision is a function of cones. There are various tests for color vision. Most commonly employed test is using Ishara plates. Patterns of colored and gray dots which reveal one pattern to normal individuals and another to color deficient individuals. This is the Ishara chart where you can identify the number gray dots which reveal one pattern to normal individual to another color in deficient. These gray dots will appear as one color to the normal individual and they appear as different color to the colorblind person. You have to identify this number in the chart. This is number 12. You have to identify this number in Ishara's chart. This is number 5. You have to identify the numbers by in the Ishara's chart based on their color. This is a mixture of various colors. This is only a single color. Ishara's plates is a quick method of screening for color vision. Holmgren wool test. Different colored wools are placed together. The subject will be given one colored wool and asked to pick up the similar colored wool. That is called Holmgren's wool test. We'll place different types of wools and we'll give one color and ask the patient to identify the similar colored wool. That is called Holmgren's wool test. Green lantern test, Eldridge green lantern. This is the subject has to name the various colors shown to him by the lantern and the judgment is made by the mistake he makes. The subject has to identify the various colors shown to him. Here there are various colors present in the lantern. The subject has to identify the various colors shown to him. This is the yellow, this is red, black, this one is blue, this is green, dark green, light green. The subject has to identify the various colors shown to him in the lantern and judgment is made by the mistakes he makes. This is called Eldridge green lantern. Francois Mullen's 100 hue test. It is a spectroscopic test in which the subject has to arrange the colored chips in the ascending order and color vision is judged by the error score. He has to arrange the colored chips in an ascending order. That is called Farnsworth Mullen's test. City University test, spectroscopic test where central colored plate is to be matched to the closest hue from surrounding colored plates. The central colored plate is to be matched to the closest hue. This is the closest hue in the 4 surrounding plate. That is called City University test. Nagel's anomalouscope. In this test, observer is asked to mix red and green colors in such a proportion that the mixture should match the given yellow colored disc. Should mix the red and green colors so that it should match the given yellow colored disc. This is the given yellow colored disc, so you should mix them until the color becomes similarly bright as this one. That is called Nagel's anomalouscope. The judgment should be made from relative amount of red and green colors and brightness setting used by the observer. We should mix the red and green colors so that the target yellow color will be similar to the target color until the red and green together becomes the target yellow color. And the judgment is made from the relative amount of red and green colors and brightness setting used by the observer. That is called Nagel's anomalouscope. And the third investigation is slit lamp examination. Used to examine the anterior segment of the eye. An arrow slit beam principle is an arrow slit beam of very bright light produced by the lamp. This beam is focused onto the eyes, which is viewed under magnification with control illumination. An arrow slit beam of very bright light produced by the lamp. This beam is focused onto the eyes, which is viewed under the magnification with control illumination. Optics of slit lamp examination, it works on the same principle as the compound microscope. The objective lens is towards the patient. The power of the objective lens is 22 diopters, is towards the patient, whose eyes forms the object. The objective lens consists of two plano-convex lenses with their convexities facing towards each other. The objective lens is towards the patient, whose eyes form the object. The objective lens consists of two plano-convex lenses, their convexities facing towards each other. The eyepiece lens, which is used by the surgeon, is plus 10 diopters to plus 14 diopters and is towards the examiner. There will be two objective lenses and two eyepieces. The illumination system can be adjusted to vary the width, height, angle of incidence of light beam. The illumination system can be adjusted. There are two objective lenses and two eyepieces varying from plus 10 diopters to plus 14 diopters. Two objective lenses are plus 22 diopters. The objective lens is towards the patient and eyepiece is towards the examiner. And the illumination system can be adjusted to vary the width, height, and the angle of incidence of the light beam. This is the optics of slit lamp examination. Methods of illumination: diffuse illumination, direct illumination, indirect illumination, retroillumination, specular reflection, sclerotic scatter, auxiliary illumination of wave. These are the various methods of illumination: diffuse illumination, direct illumination, indirect illumination, retroillumination, specular reflection, sclerotic scatter. A diffuse broad beam of light is used and a general view of anterior segment of the eye is observed. A diffuse broad beam of light is used and a general view of the anterior segment of the eye is observed in diffuse illumination. Direct illumination, the slit lamp and microscope are focused on the same area and examination is performed. Changes in the corneal stroma and epithelium are better noted by this technique. By direct illumination, changes in the corneal stroma and epithelium are noted by this technique. That is direct illumination. The slit lamp and the microscope are focused on the same area and examination is performed. That is direct illumination. In indirect illumination, the slit lamp is focused just besides the area to be examined. In direct, it is focused on the same area where it is examined. It is used for the changes in the stroma and epithelium. That is direct illumination. Indirect illumination, the slit lamp is focused in a position just beside the area to be examined. You know the difference now between direct illumination and indirect illumination. Direct illumination is slit lamp and microscope are focused on the same area. In indirect illumination, it is focused adjacent to the area to be examined. Corneal microcysts and vacuoles can be best observed by this method, indirect illumination. Retroillumination, light is reflected off the iris or the fundus, while the microscope is focused on the cornea. Microscope is focused on the cornea. Light is reflected onto the iris. It is especially useful in detecting corneal edema, neovascularization, microcysts, and infiltrates. The advantage of retroillumination is detecting the corneal edema, neovascularization, microcysts, and infiltrates. Specular reflection, here the angle between the slit lamp and microscope is increased to 60 degrees. Specular reflection is the angle between the slit lamp and the microscope is 60 degrees. The angle of incidence is equal to angle of reflection. Changes in the endothelium like polymeganism, Gette, and others can be observed. This is the advantage of specular reflection. Sclerotic scatter, it utilizes the phenomena of total internal reflection. The slit beam is focused onto the temporal limbus and passes through the cornea. It outlines any subtle stromal and epithelial opacities which may lie in the path. Oscillatory illumination of OFP. In this, the beam is given an oscillatory movement by which it is often possible to see minute objects or filaments, especially in the aqueous which would otherwise escape detection. Oscillatory illumination. This is used for detecting the aqueous humor, any changes in the aqueous humor. That is particularly in uveitis. You can see the Tyndall's phenomenon. These are the various illuminations: direct, indirect, diffuse, specular, sclerotic scatter, and auxiliary illumination of wire plane. Specular reflection means angle of incidence is equal to angle of reflection. There is a angle of 60 degrees between microscope and the slit lamp. That is called specular reflection. This is another investigation, retinoscopy or skioscopy or shadow test. It is an objective method of finding out the refractive errors by the method of neutralization. Foucault's principle: when light is reflected from a mirror into the eye, the direction in which the light travels across the pupil will depend upon the refractive status of the eye. Light travels across the pupil will depend upon the refractive status of the eye. That is the principle of retinoscopy. Types of retinoscopies: plane mirror retinoscopy, plane and concave retinoscopies, self-illuminating retinoscopies, spot retinoscope, and streak retinoscope. We most commonly use streak retinoscope. The distance between the patient eye and the observer while performing the retinoscopy normally at a distance of 66 centimeters or 50 centimeters. To compensate we use working distance lens. Instant identification of the refractive error like myopia, hyperopia, and astigmatism. The target is given to the patient should be 20 by 200 or 60 by 60 in Snellen's chart. You should give this is the patient, this is the examiner, and this is the target. It should be a distance of 6 by 60 in the Snellen chart. It is given to the patient to relax the accommodation during retinoscopy. Light is directed into the patient side to illuminate the retina. There are various types of retinoscopy: dry retinoscopy and wet retinoscopy. Dry retinoscopy is without any cycloplegia. Wet retinoscopy is with cycloplegia. Indications for wet retinoscopy includes accommodative fluctuations indicated by the fluctuating pupil or reflective retinoscopy, patients with esotropia or convergence excess esophoria. You should know the difference between dry retinoscopy and wet retinoscopy. Dry retinoscopy means if you perform retinoscopy without giving any cycloplegia, it is called dry retinoscopy. If you perform retinoscopy with a cycloplegia, it is called wet retinoscopy. Indications for retinoscopy includes patient with esotropia or convergence excess esophoria. The retinoscopy result significantly more positive or more minus than the subjective result. If there is more positive or significantly more minus than the subjective result, then also you should perform wet retinoscopy. What are the cycloplegic drugs used in wet retinoscopy? You usually use atropine sulfate 1%, cyclopentolate 1%, and hometropine 2%. These are the cycloplegic drugs used in retinoscopy. Atropine sulfate 1%, cyclopentolate 1%, hometropine 2%. This is a picture of autorefractometer, computerized eye testing. Refractometry, also called optometry, objective method of finding out the error of refraction by using refractometry is called refractometry. Utilizes the principle of indirect ophthalmoscopy. Conventional refractometers: dioptron, ophthalmometron, Henker's parallax refractometer, coincidence refractometer. These are the various types of refractometer. Hello? What's it? These are the various types of conventional refractometers: dioptron, ophthalmometron, Henker's parallax refractometer, coincidence refractometer. Computerized autorefractometry. This is the most commonly used nowadays because it gives quick information in terms of spherical, cylindrical, and axis and interpupillary distance. Good alternative to retinoscopy in busy practice. Advantage of mass screening. Advantage includes mass screening and research programs and epidemiological study. The subjective verification of refraction is must even after autorefractometry. This is computerized eye testing. We most commonly use nowadays computerized eye testing. Presently, it is most commonly used because of the quick information in terms of spherical power, cylindrical power, and axis and interpupillary distance. Good alternative to retinoscopy in busy practice. It is also advantageous for mass screening, research programs, and ecological research. The subjective verification of refraction is a must even after order. Even if you do computer eye testing, then you have to go for subjective verification. Keratometry, also called ophthalmometry, an objective method of estimating the corneal astigmatism by measuring the curvature of the central cornea. Principle of keratometry includes this is a keratometry is another investigation also is also called ophthalmometry. It is an objective method of estimating the corneal astigmatism by measuring the curvature of the central cornea. Based on the fact that the anterior surface of the cornea acts as a convex mirror, so the image size produced varies with its curvature. Therefore, from the size of the image formed by the anterior surface of the cornea, first working image, the radius of curvature of the cornea can be calculated. The accurate measurement of the image is obtained by using principle of visible doubling. These are the various types of keratometer. This is a Jawel-Schwarz model keratometer. This is Bosch and Lamb keratometer. We use Bosch and Lamb keratometer. Almost all the ophthalmologists use Bosch and Lamb keratometer. In this, the mites are formed in the form of circles. The radius of curvature of the cornea is horizontal and vertical. This is the horizontal, this is the vertical meridian. Can be measured simultaneously without rotating the mites. You have to superimpose these mites until they form a plus sign like this. These mites have to be superimposed onto the cornea until they form a plus sign like this. This is a picture of fundus. There is a test is called ophthalmoscopy. Clinical examination of the interior of the eye by means of ophthalmoscope primarily used to assess the state of the fundus and detect the opacities of the ocular media. For diagnosis of diabetic retinopathy, hypertensive retinopathy, any sickle cell retinopathy, any changes in the fundus, glaucoma, optic neuritis, macular edema. For all the diseases of the retina, you have to do ophthalmoscopy. You can see here the optic disc. These are the blood vessels, veins. These are the arteries, central retinal vein, and this is the central retinal artery. This is the optic disc. This is the macula, and this is the pore. This is the temporal retina, and this is the nasal retina. To assess the posterior fundus, you have to do ophthalmoscopy. Ophthalmoscopy methods of the examination: distant direct ophthalmoscopy, direct ophthalmoscopy, and indirect ophthalmoscopy. And the differences between direct ophthalmoscopy and indirect ophthalmoscopy includes the condensing lens is not required in direct ophthalmoscopy, whereas condensing lens is required in indirect ophthalmoscopy. Examining distance, it is as close to the patient as possible for direct ophthalmoscopy, at an arm's length in indirect ophthalmoscopy. And image formed in direct ophthalmoscopy is visual and direct, whereas real and inverted in indirect ophthalmoscopy. Illumination not as bright, and it is not useful in hazy media in case of direct ophthalmoscopy. Illumination is bright and is useful for hazy media in indirect ophthalmoscopy. Area of field in focus is about 2 disc diameters, is about 8 disc diameter. The larger field of area is examined in indirect ophthalmoscopy. It is useful for hazy media also. Indirect ophthalmoscopy is useful for hazy media also. Image formed is real and inverted. Accessible fundus fluid slightly beyond the equator. You can see up to the vara serrata, i.e. the peripheral retina. You can see if there is any holes in the peripheral retina, if the patient is having high myopia, if the patient is having any peripheral retinal detachments, rhegmatogenous breaks in the peripheral retina, then indirect ophthalmoscopy is very useful. Here you can do a prophylactic laser. In retinopathy of prematurity, all these conditions, you have to go for indirect ophthalmoscopy. Examination through the hazy media not possible. It is possible in indirect ophthalmoscopy. These are the advantages of indirect ophthalmoscopy. Bright, useful in hazy media. You can see the large area. Stereopsis is present. You can see up to the vara serrata and peripheral retina. Examination through the hazy media is possible. These are all the advantages of indirect ophthalmoscopy. And the image formed is real and inverted. in indirect ophthalmoscope. Whereas the direct ophthalmoscope, stereopsis is absent. You cannot see beyond the equator. Slightly, you can see only beyond the equator. Not possible in the hazy media. Illumination is not as bright. Image formed is virtual and direct. There is a difference between direct ophthalmoscopy and indirect ophthalmoscopy. Magnification is 14 times. Indirect method it is 3 times. Field diameter is 2 dimension diameter. It is a 9 dimension diameter. Ratio of area field, 1 field, 20 fields. Illumination, limited illumination, high illumination. Depth of focus, small range of focus. Whereas indirect method, it is large range of focus. Stereopsis is absent, present in indirect method. Orientation of image is direct. It is inverted and reverse. View of periphery limited. You can see the full peripheral retina in indirect ophthalmoscope. Scleral orientation is difficult. It is easy in indirect ophthalmoscope. This is a picture showing direct ophthalmoscopes. These are the direct ophthalmoscopes. This is a indirect ophthalmoscope where you have to keep the this to the head, and you should see through this lens, condensing lens. Through this lens, and you will have a 20 diopter condensing lens in between this head loop and the patient. You have to hold a 20 diopter condensing lens between the patient and this head loop. You have to keep this under the head. And you have to adjust this interpupillary distance, and you should see through this lens. This is a picture of indirect. This is the condensing lens of 20 diopters. This is a direct ophthalmoscopy where you have to go close to the patient. This is indirect ophthalmoscopy where you can see. And this is the condensing lens. Gonioscopy for visualization of the angle of the anterior chamber. Indirect gonioscopy. Direct gonioscopy. Indirect gonioscopy provides mirror image of the opposite angle. Goldman and G's gonio lenses are indirect gonioscopy, where direct gonioscopy provides direct view of the angle. Example of Koyapis gonio lenses. Goldman and G's are indirect lenses, where you will see the opposite angle. Whereas Koyapis gonio lenses, you see the same angle, direct view of the angle. There are two types of gonioscopy, indirect and direct gonioscopies. Gonioscopy is biomicroscopy examination of the angle of the anterior chamber using gonio lens. Indirect gonioscopy and direct gonioscopy. Indirect gonioscopy provides mirror image of the opposite angle, where you will use Goldman and G's gonio lenses, where a direct gonioscopy provides direct view of the angle, Koyapis gonio lens. Angle structure seen from behind forwards, root of the iris, anteromedial surface of the ciliary body, scleral spur, trabecular meshwork and Skene's canal, and swell baseline. These are the structures seen from behind to forwards. Root of the iris, ciliary body, scleral spur, trabecular meshwork and Skene's canal, and anterior, more anterior is swell baseline. Most posterior is root of the iris, more anterior is swell baseline. These are the structures seen in the angle. This is the root of the iris, ciliary body, scleral spur, trabecular meshwork and Skene's canal, and swell baseline. These are the structures. This is an open angle. This is a closed angle. Closed angle glaucoma, what happens? There will be mid-dilated pupil. Due to mid-dilated pupil, there will be opposition between the lens and the iris. So aqueous will not go from the anterior chamber into the posterior chamber. So aqueous gets accumulated behind the iris. So this aqueous which gets accumulated behind the iris will push the peripheral retina towards the angle. So aqueous will not gain. So there will be rise in intraocular pressure. That is called closed angle glaucoma. Application of gonioscopy. It is useful for classification of glaucoma into open angle and closed angle based on the configuration of the angle. Localization of foreign bodies, abnormal blood vessels or tumors in the angle. Demonstration of extent of peripheral anterior synecdoche (PAS) and hence planning for glaucoma surgery. Direct gonio lens is used for goniotomy. Gonoscopic grading of the angle width, grade 4, 35 to 45 degrees, wide open angle. Chance of closure is nil. Structure visible are small waistline, trabecular muscle, scleral spur, and ciliary body band. Grade 3, angle width is 20 degrees to 35 degrees, open angle. Chance of closure is nil, and structures visible are sharp waistline, trabecular muscle, and scleral spur. Ciliary band is not visible. Grade 2 is 20 degrees, moderately open. Chance of closure is possible. Structures visible are small waistline and only trabecular muscle visible. Scleral spur and ciliary body band are not visible. Grade 1 is 10 degrees angle width. Configuration is very narrow. Chance of closure is highly possible. Only shallow baseline is visible. Trabecular muscle, scleral spur, and ciliary body band are not visible. In grade 1 angle closure. Grade 0 closed angle or completely chance of closure is closed. This is already closed angle. Structures visible, no structures are visible. This is the sharper's grade. The A-scan biometry, commonly referred to as A-scan. This thin parallel sound beam is emitted from the probe tip with an echo bouncing back into the probe tip, and sound beam strikes the interface. An interface is the junction between any two media of different densities and velocities. Anterior corneal surface, aqueous or anterior lens, these are the various interfaces. Aqueous or anterior lens surface, posterior lens capsule or anterior vitreous space, posterior vitreous space or retinal surface, choroidal or anterior scleral surface. These are the various interfaces. Indications for A-scan, biometry for accurate axial length measurement for IOL calculation, morphological characteristics, AC depth, corneal thickness, lens thickness, and to detect the measure the differentiate tumors and follow up. This is how we perform the A-scan. IOP measurement, direct and indirect. Direct is manometry, indirect is tonometry, contact tonometry, and non-contact tonometry. Non-contact is divided into air puff tonometer, pulse air tonometer, expert tonometer, Gorman air blast tonometry, Killer's pulsar tonometry. Contact tonometry, indentation and applanation. Indentation is Shiraz, Harrington tonometer, Grant's tonometer, and Morrissey tonometer. Applanation is Goldman applanation tonometer, Perkins applanation, McKay-Mark tonometer, and tonometer. These are the various types of applanation tonometer. We usually use Goldman applanation tonometer. We use Shiraz tonometer. It consists of weights. You can see where you 5.5 grams, 7.5 grams, 10 grams. These are the weights here. This is how you have to keep the dash tonometer under the cornea, and you have to measure the pressure here. This is Goldman's applanation tonometer. These are the various parts of Goldman's applanation tonometer. This is the part how it is connected to the slit lamp. This is the bioprism. This is the fader arm. This is the control weight insert. This is the housing. This is the adjustment knob. This is the adjustment knob. These are the parts of Goldman's applanation tonometer. This is a toner pen. This is Perkins applanation tonometer. These are the various investigations in ophthalmology. If you remember the headlines also, that is important. Gonioscopy, A-scan biometry, keratometry, visual acuity, tonometry, non-contact and contact tonometry. If you remember the headlines, that is also sufficient for you, undergraduate level. Ophthalmoscopy, direct ophthalmoscopy and indirect keratometry, and Bosch and Lamb keratometer and Javel's keratometer. Autorefractometer, computerized eye testing. These are the various investigations in ophthalmology. Retinoscopy. Retinoscopy is very important. You have to differentiate between dry retinoscopy and wet retinoscopy. Dry retinoscopy is without any cycloplegia. Wet retinoscopy is with cycloplegia. Retinoscopy is very important. Ophthalmoscopy, retinoscopy, slit lamp examination, various types of illumination, diffuse illumination, direct illumination, indirect illumination, retroillumination, specular refraction, sclerotic scatter, oscillatory illumination. These are the various types of illumination. These are the cycloplegic drugs used in wet retinoscopy: atropine, cyclopentalate, and hometropine. You should remember the principle of keratometry based on the fact that antisurface of the cornea acts as a convex mirror. That's the principle of keratometry. It is a method of objective method of estimating the corneal astigmatism by measuring the central curvature of the cornea. Refractometry is objective method of finding out error of refraction by using refractometer. That is called refractometry. This is a computerized refractometer. This is a color vision, testing of color vision, transverse lens test, Holgren's wool test, Eldridge green lantern test. This is a Holgren wool test. We have to give a target wool and we will ask the patient to examine the similar wool and the mixture of various colored wools. This is Ishihara's charts. The patient has to identify the numbers in between the dots. Ishihara's charts is most commonly used. This is a checking for near vision, Snellen's near vision chart. This is a distant vision, Snellen's distant vision chart. Visual acuity test. Snellen's distant vision chart and Snellen's near vision chart. This is a near vision chart. This one is a near vision chart. This is Ishihara's chart. Slit lamp examination. Retinoscopy. Computerized eye testing. Order refractometer. Keratometry. Bosch and lamp keratometry. Ophthalmoscopy. Fundus examination. Direct ophthalmoscope and indirect ophthalmoscope. And techniques of direct ophthalmoscope and indirect ophthalmoscope. Gonioscopy. Direct gonioscopy and indirect gonioscopy. And this is the open angle and closed angle. A-scan biometry. IOP measurement, indentation and appellation tonometry. This is indentation tonometry. This is Goldman appellation tonometry. And non-contact tonometry. We have Goldman appellation tonometer where this is available in all the institutions. This is a standard biprism. This is where it is connected to the slit lamp. This is the biprism. This is the feeder arm. Weight insert. This is the housing and this is the adjusting knob here. This is the adjusting. Here you can see the measurements here, reading. This Goldman supplementation tournament.